Thank you so much, Dr. Mustafa, for the nice introduction. And first, I would like to thank the organizing committee for the invitation, especially Dr. Ayman. And it's an honor to be standing before you talking about the topic of genetic counseling and breast cancer as the only genetic counselor participating in this event, and hopefully in future events we'll have more representation of genetic counselors. So today we'll be talking about the genetic counseling role in preventing and diagnosis of hereditary breast cancer. A very, I would say, important topic, and a lot of public awareness about it is needed. All right. So in my talk today, I will be talking briefly about the hereditary breast cancer, give you also a brief about both genetic counseling and the role of genetic counseling, identifying individuals who should receive genetic testing, and also presenting you some approaches pertaining to genetic testing, germline genetic testing when it comes to hereditary breast cancer. And to make it more applicable, we'll apply all of that knowledge and approach into a real life case scenario, and then we will conclude. I am a salaried employee of NRL. I also provide genetic counseling services at Cleveland Clinic, Abu Dhabi. My salary doesn't increase if more testing comes to an NRL. Okay, so to make this more interesting and applicable, this is one of the cases that I have seen in clinic, in Cleveland Clinic, Abu Dhabi, for a lady where the arrow points. She's 57, had a history of breast cancer, invasive breast cancer in 2012. She recently had a brother who developed prostate cancer at 54. He's currently 55, and also had melanoma at 52, and undergoing genetic testing actually had a 24 gene panel that came back positive for a CHEK2 mutation. And then, then the lady came to me for advice and counseling about any testing that she needs to undergo. Basically, this case will dig, deeper in it, but before that, I'll give you some background information, so stay tuned. Okay, so when it comes to cancer, as you already know, cancer is the second most cause of death globally after heart disease and followed by lower respiratory diseases. Specifically, breast cancer is a global and national, local health burden, and it is one of the most common cancers in females. And as you can see in here in UAE, it comes first, as the pie chart shows, and then followed by thyroid cancer and colorectal cancer. Interestingly, here in the Arab world and also in UAE, we see, through publications that, through the published data, that there is a tendency for females to develop breast cancer around 10 years earlier than their counterparts in the Western countries. When we talk about genetic, when we talk about breast cancer, usually it is classified. The majority of cases of breast cancer are sporadic, because usually the majority are, and when you talk about breast cancer disease, you're describing a multifactorial disease rather than a genetic disease. But that being said, there is around 15 to 20% familial cases that runs in families. But when the genetic cause is identified, it becomes hereditary, and it constitutes around 5 to 10%. Majority of cases, I would say half or 2/3 of these cases are caused by germline mutations, inherited mutations in BRCA1 or BRCA2 as the number one. And then, of course, there are other genes that could be associated with the increased risk for hereditary breast cancer, including PAL2, PTEN, CDH1, ATM, CHEK2, and many more. Whenever we talk about breast cancer, I would always like to bring the example of what we call the Angelina Jolie or the Angelina Effect. It's basically a global phenomena. As you probably already know, that Angelina Jolie tested positive for BRCA1 mutation. And that was in 2013 when she appeared on the cover of the Time magazine, and they coined the magazine coined the term the Angelina Effect because of the I would say the significant impact. It's a long-lasting impact of a celebrity on public health awareness that was coupled by increased number of women undergoing genetic testing and also undergoing the risk-reducing surgeries like mastectomies and oophorectomies. I would like to use this example a lot in my clinic because most of my patients, when we start discussing BRCA1, BRCA2, have no idea what BRCA1 and BRCA2. But once I bring the Angelina Jolie card and talk about her experience, it seems like everyone knows her story. So it's kind of a good effect and a nice segue to talk about this topic of risk. When it comes to the genes, as we said, the most significant genes in this case is the BRCA1, BRCA2 because of they're considered to be high risk or highly penetrant genes because they're associated with increased risk for breast cancer that could reach up to 85%, and also could increase risk for ovarian cancer that could reach up to 54%. Sometimes some studies say more, maybe around 60%. And then in males, it could be associated with male breast cancer, but less than 10%, and also prostate cancer, which could also reach up to 30%, especially with BRCA2 mutation. There are other slight increase in risk with pancreatic cancer and melanoma. Other genes are also could be classified as high risk, medium risk, or low risk, and the risk and the type of risk, the type of tumors that could be at risk for, or the percentage of this risk is variable among different genes. All right, so what do we do in order to determine who should be offered genetic counseling, genetic testing for hereditary breast cancer? Obviously, we have criteria, and these are the NCCN, as you know, the NCCN guidelines that actually give us a nice guidelines and criteria for who should be offered genetic counseling and genetic testing, and these are widely used and they're periodically updated. So in order to put all of these together, you know, they depend on basically a lot on the personal history of the patient, the family history. So we as genetic counselors try to collect a lot of information when it comes to the patient's personal history and family history. And, you know, these are basically some of the, scenarios that we encounter routinely in clinic. So if we start from left to right, so the first case, as you can see, is a young onset breast cancer before the age of 45 or below, and this is by itself is enough criteria for counseling and testing. The second case, as you can see, is a bit later onset, 50, but there is another family member who has breast cancer, her mother basically, so she also is eligible for counseling and testing. The third case, as you can see, is also a bit late onset, but there is a mother who had ovarian cancer. Ovarian cancer, one of the basically criteria for genetic counseling and testing by itself. And then going down here on the left, we have even later onset, 65, but with a particular type of cancer, which is the triple negative. And the triple negative cancer by itself at any age is a criteria for counseling and testing, but also had a brother with breast cancer, which by itself is a criteria because it's so rare. And also the other one is a 67, a quite late onset, but it is a metastatic breast cancer. And genetic testing here is for the purposes basis of treatment rather than hereditary clarification, because of to guide the treatment, especially PARP inhibitors, if it is like a BRCA1, BRCA2 positive. And the last one is when you have a known mutation in the family, obviously we need to test other family members for that particular mutation. Okay, so these are the general criteria which we covered. Usually young onset before the age of 50, usually having multiple individuals diagnosed with breast cancer, having related forms of cancer, like for example ovarian and breast cancer in the same family, having multiple primary tumors, like multiple primary in the breast cancer, for example, individuals with certain types of histology like triple negative cancer, as we mentioned, and then the presence of rare cancers like male breast cancer, ovarian cancer, pancreatic cancer, or for example the metastatic prostate cancer, and obviously finally is having a known confirmed familial mutation in the family, like a BRCA1 mutation in the family. The best person to do that, the best man or the best woman to do that is genetic counseling, because we kind of invest a lot of time trying to figure out the personal and family history, and trying to explain to the patient their best options in testing and counseling. As you know, genetic counselors are master's trained healthcare providers. They combine their knowledge of, they have training in medical genetics and counseling theory. They, combine that with a very particular set of skills, including interpersonal communication, genetic risk assessment, education to patients, and counseling theory. They combine all of that to provide the patient with the genetic counseling service for a variety of genetic or genomic indications. Genetic counseling is a multi-process, usually a multi-step process, starting with collecting information about the patient's personal and family history, and providing risk assessment based on that, providing background information, for example, on genes, chromosomes, genetic conditions with layman terms, and also providing pre and post genetic test counseling. And usually it starts with determining if testing is appropriate or not, and whether if it is appropriate, what is the best test that if you go to kind of the genetic testing registry, you'll find like thousands and thousands of different types of testing. So it becomes complicated. You need someone who kind of will versed in this to choose the best test to offer the patient. And after that, you have to kind of determine who in the family is the best person to be tested, who's the most informative. And then when the results come back, obviously we try to explain the results for the patient and the implications of testing, and also if there is any options of management and prevention. And finally, we provide assistance also in testing other family members if the test comes back positive, and also giving kind of reliable resources and psychosocial support for the patient. All right. Luckily, we at National Reference Lab, in cooperation with the Cleveland Clinic Abu Dhabi, we established one of the, I would say, first clinical specialized genetic counseling clinics, physically located in Cleveland Clinic Abu Dhabi, that was officially launched around the mid of 2020, and it offers genetic counseling for a variety of indications, mainly breast cancer, hereditary breast cancer indications. For about 80 to 90% of our referrals are like that, and then we serve other kind of specialties in the hospital, and also outside the hospital we receive also external referrals locally, and recently we start to receive international referrals from the surrounding countries. So far we have counseling around close to 400 families with, as we said, different indications. All right. So when it comes to genetic testing, usually the best approach to adopt when you're trying to look for if the breast cancer is hereditary or not is using a multi-gene panel as the most, I would say, effective approach. It has a higher sensitivity and detection rate, and also it is cost effective. When it comes to gene panels, and as you know, you have smaller panels, you have medium panels, you have bigger panels. Which one we should use? Usually there is, I would say, advantages and disadvantages for each approach. If you go for the more expanded panels, usually it has a higher sensitivity, higher detection rate, and also it helps detect some mutations, less common genes, and with a negative result with a bigger panel, usually it's a better reassurance for the patient. Some of the disadvantages for that approach is the increased likelihood of finding uncertain variants that could sometimes we don't necessarily know what to do with them, and sometimes also we could unmask mutations in some low risk or low penetrant or medium penetrant genes that we don't necessarily have clear guidelines on how to manage these patients. This is just a hypothetical example of this consultant where she has a breast cancer at 47. If we start with testing her with only BRCA1, BRCA2, and she has a mutation in other gene, she obviously would be missed. Because there's a lot of practices who only offer BRCA1, BRCA2, and that's not kind of the best approach and goes against the guidelines. Having a slightly bigger also might not help because the mutation might be in a gene like PAL2 or RAT51 or C or D. So sometimes you have to kind of manage, the number of genes that you have to choose without kind of compromising the detection rate. All right. We at the National Reference Lab recently have launched a genetic test panel for cancer genes with specialized, with the shorter version for the 14 gene breast cancer panel. And also we have a bigger panel, 47 gene, that we actually do for common hereditary cancers, especially breast cancer, colon cancer, hereditary colon cancer, pancreatic cancer, uterine cancer, and others. Some of the benefits for performing germline genetic testing could include confirming a hereditary cancer diagnosis, obviously enabling the treating physician to come with the best approach and the best management plan for the patient based on the result. That could be in the form of increased surveillance. It could be some choice of treatments for certain genes that are mutated, and also offering some of the options like risk-reducing surgeries like mastectomies and oophorectomies for the patients. Also, knowing or detecting a mutation in the family would kind of enable the testing of other family members who might be at risk, especially first and second degree relatives who might be up to 50% chance of having the same mutation. So that's something that is helpful. Also enabling some of the preventive reproductive options like PGT or pre-implantation genetic diagnosis once the mutation is known. And finally, if the result is negative, it is relatively reassuring for that family member. Now, getting practical and trying to apply all of this into our case that we showed at the beginning. Again, just to remind you, we said that this is my patient 57 with a history of breast cancer in 2012. She has a quite of history when we took the kind of pedigree. The father before that, he is currently 84, but had multiple types of cancer. Especially the most significant ones are prostate cancer, early 50s, and also colon cancer around the same time. Had a skin cancer like basal cell carcinoma in his 70s on his face, and also non-Hodgkin's lymphoma at 78. Had, as we mentioned, a brother who recently developed prostate cancer and a melanoma also at 52, and tested positive for CHEK2 mutation. CHEK2 gene mutation, and also, as you can see in the family pedigree, that this our patient had also a maternal aunt who developed melanoma in her 40s, basically, and she's now 60. Now, looking at this, pedigree, we notice that there are multiple types of cancers in the same family. The most, I would say, significant is the prostate cancer, because it's kind of there, and it's a quite young onset. There is melanoma, 2 cases of melanoma. There is, the breast cancer and all of that. So now the question becomes now, which test should I offer our patient? Should I go for the variant or the mutation that was identified in the brother, or should I go with a more holistic approach because of the different type of cancers, so that we don't miss anything? Okay. So usually, as you know, as a rule of thumb, when it comes to genetic testing for cancer syndromes, we usually go with testing someone who actually developed cancer themselves, rather than going to someone who is symptomatic, because it's a better approach and more informative approach. And that's what was done for this case. The brother was tested elsewhere, as you know, and he came back. This is the kind of a presentation of his result. He had a pathogenic mutation, and this pathogenic mutation is a gross deletion, actually, in the CHEK2 gene of exons 9 and 10. And also had a variant of uncertain significance in NTHL1 gene, which is a gene, it's a recessive gene that is associated with colon polyposis, but there is not enough evidence of pathogenicity. So for the sake of this case, we kind of ignored this result of uncertain significance, because most likely it's non-actionable. Now, going back to the rule, now, if you have a family history of cancer and you have a known mutation, usually go directly to that particular mutation. But before considering that, it's the most straightforward, it's quicker, it's cost effective, but it's not always the best approach. I mean, it is the best approach in certain scenarios, but in this case, by analyzing the family history, it's very important to take kind of the pedigree into consideration before doing that. And basically, what we decided to do is to go to a wider approach, which is actually the 84 gene panel. We consented the patient, and the patient came back with the same mutation as her brother, the CHEK2 gross deletion of exons 9 and 10. Interestingly, she came back with another gene mutation in a gene called MITF. Luckily, because we chose the bigger panel, this was not missed, and this was picked up. If we went to the approach of targeted testing, we would have missed this mutation. And then we found the other variant of uncertain significance originally found in the brother, and another gene also as the HB variant, which also both of those uncertain variants are most likely non-actionable. Now, just to give you a brief about CHEK2 gene, it is mainly mutations in this gene associated with autosomal dominant predisposition to breast cancer. The risk could reach in females up to from 28 to 37% lifetime risk for breast cancer. Colon cancer, thyroid cancer, prostate cancer is at increased risk, but the exact numbers or percentages are not well established so far. There is some preliminary evidence, but not sufficient, with association with urinary tract cancer, ovarian cancer, and melanoma. But as I said, these are not, the evidence is not sufficient so far. The MITF gene is mainly associated with autosomal dominant susceptibility to melanoma. Studies estimate the risk for melanoma to be between 2 and 5 folds increase in risk for this, and there is some emerging evidence of association with renal cell carcinoma, but again, the evidence so far is not sufficient to make this conclusion. We counseled the patient, obviously, about the autosomal dominant inheritance with a 50% chance of passing their own the mutation to the offspring, and also siblings will have the same, and the parents. All the kind of the first degree relatives will have 50% chance of having the same mutation. Who should we test? Basically, the children here are 27, 20, they are adults, so we can offer them testing. Her siblings, especially the the two sisters, and also the brother should be also tested the MIT because most likely he will test positive because he already had melanoma, and other family members like parents and uncles and aunts from both sides should also be offered testing. In terms of management, for the NCCN guidelines, recommend in the case of CHEK2 mutations, if someone has a mutation because of the increased breast cancer, usually increased surveillance should be offered through mammograms and MRI. And but in terms of surgical reduction, risk-reducing surgeries like mastectomies, it is not, I would say, recommended because there is not enough evidence to recommend it, but can be considered based on the personal and family history in this case, and also because of the increased risk for colon cancer. Colonoscopy could be offered for the patient every 5 years or 10 years earlier than the first case in the family. And for melanoma, usually it's also increased surveillance, self-exams, or could be done by full body clinical skin exams every 3 to 12 months, beginning at puberty or at the time of diagnosis, and obviously general sun protection. For our patient now, she's following up with the high-risk program for the breast cancer. She's doing the surveillance, she's doing the colonoscopies, she's also going to the dermatology clinic for the skin exam, and also she's on tamoxifen for quite a while now to reduce the risk of breast cancer. And just to conclude, breast cancer, the most common cancer in females with the hereditary type is being 5 to 10%. Hereditary breast cancer is caused by pathogenic mutations beyond BRCA1, BRCA2. And also genetic counselors, as you know now, are trained healthcare providers with an essential role in providing genetic counseling and also testing for patients and their families with suspected hereditary cancer syndromes. Guidelines and Germline for Germline testing are there and are available to advise who should be offered genetic testing and counseling. Germline genetic testing pertaining to hereditary breast cancer has a lot of benefits, especially in the management of the patient, prevention and risk assessment. And by this, I finish my presentation. Thank you so much for your attention. I'll be glad to take your questions. Thank you.